about endodontic periapical lesions, why and what. And I chose this topic because it's fundamental and I want to make it as easy as possible. So I hope you will enjoy this topic today. Sorry, let's stop. Ivy?
Yes, I'm here.
I'm sorry, stop recording because I could not control my my laptop.
Okay, so yeah.
Ivy particularly for, yes.
Okay.
You will say 3, 2, 1 and I will start.
Yeah.
And what? And I chose this topic because it's fundamental and I want to make it as easy as possible. So I hope you will enjoy me and let's start. Let me remind you with the goal of endodontics. The main goal of endodontics is to prevent or treat periapical lesions so that the tooth can be retained in the oral cavity in healthy condition. So we hope after treating a periapical lesion, this periapical lesion will disappear and the tooth will back to its function. But what is periapical lesion and why they occur? So let's first discuss why they occur. Periapical lesion is directly associated with the presence of bacteria in the root canal space. So it is very important to bear in mind, without microorganisms, no periapical lesion will occur. And this fact was so obvious since 1965, when Kakehashi told us microorganisms are essential for the progression and perpetuation of different forms of apical periodontitis. So we accepted this fact since that time. Without microorganisms, periapical lesion will not form. Now, let's see how bacteria will enter inside the root canal system and what are the routes of infection. We have several routes. First, caries and decay, trauma-induced fracture, cracks, either microscopic or macroscopic. And by the way, sometimes you see a tooth which seems sound without anything, without any decay, and you will be shocked. You will see periapical lesion. Why? Because we might have a sort of cracks inside the enamel. Another route, while we are making drilling and restorative procedure, we might go deep and make exposure, and when we make exposure, the microorganisms may enter inside and cause infection of the pulp. Scaling and root planning might be a route for the microbes to enter inside, and attrition or abrasion might cause infection of the pulp by making the microbes enter inside. So let's focus on the main way for root canal infection, which is a caries route. Here, let's see the story from the beginning. Bacteria within carious lesion will destroy the tooth structure. And we can see a patient who comes to our clinic with decay in the tooth, as this picture here. When the caries start, which means it has bacteria inside this carious lesion, the bacteria will diffuse, and bacteria, of course, by themselves and bacterial by products, they will diffuse through the dentinal tubules and they will go toward the pulp. Now, this is very important to remember. Bacteria will gain access to the pulp when the dentine distance between the border of the carious lesion and the pulp is 0.2 millimeter. So when you feel you are close to the pulp, we have a high tendency of microorganisms to enter through the dentinal tubules. 0.2 millimeter is the distance which we consider it as a risky distance. Now, the pulp surface becomes colonized and covered by bacteria, and they become severely inflamed. Then, this bacteria and bacteria byproducts will affect the surface of the pulp, and now we have inflammation of the pulp surface, as we can see in this X-ray. At this moment, we might have what we call irreversible pulpitis. Irreversible pulpitis means the vital inflamed pulp is incapable of healing. And the patient will come to our clinic with 3 major symptoms. First, spontaneous tooth pain. So the pain will start without any stimulation. Second, the nature of pain, it is sharp, severe pain. Third, there will be prolonged response to cold stimulus more than 30 seconds. So when the patients tell you, I have spontaneous, sharp, prolonged pain, bear in mind we might have irreversible pulpitis. If we take X-ray for this tooth, radiographically, we might see slight widening of the periodontal ligament space, and this widening of lamina dura is apparent on the X-ray, as we can see in this X-ray here. Now, if the patients that did not take any treatment from the dentist, or the patient, he was ignorant and he did not go to a dental clinic, what will happen? The bacteria and bacterial byproducts will multiply, and it will affect the pulp, and the pulp inflamed, and it will go to become necrotic. So the pulp now is dead and necrotic. And we can see this phenomena of what I call suicidal reaction when we have inflammation in the pulp, in the nail, and in the brain. And those 3 parts of the body, they are participating in one feature. We don't have enough space to expand when we have inflammation. So when we have inflammation, there is no space to expand, as what happened in regular inflammation. So the organ, it will die, like what will happen in case of the pulp. And now our pulp is dead or necrotic. So we have to remember, necrosis of the pulp tissue is a prerequisite for the establishment of a primary endodontic infection. If we don't have pulp necrosis, we will not have periapical lesion or growth of microorganisms inside. Now the pulp is necrotic, and a necrotic pulp is an ideal environment for various microorganisms colonization. Why? Because we have moist, warm, nutritious, and low amount of oxygen, or it's anaerobic. So this is an ideal condition for microorganisms to multiply and grow. And when we talk about microorganisms, we have several types of microorganisms like bacteria, like parasite, like viruses, like fungi. But bacteria are the main microorganisms implicated in the periapical periodontitis. So we will focus on bacteria, and we will talk a lot about bacteria in case of necrotic tooth. Now, let's take a close look for the bacteria which exist in the necrotic pulp. We are dealing with mixed community of bacteria. We are not dealing with one type of bacteria. We have more than 20 species of bacteria. So they are between 10 or 20 species of bacteria inside the pulp space. And the number of those bacteria is between 1,000 to 100 million bacterial cells in chronic cases. In case of acute cases, this number will increase. What are the types of the bacteria inside the pulp space? The predominance of anaerobic bacteria like Bacteroides, Porphyromonas, Fusobacterium exists there. There is no strong evidence supporting the specific involvement of a single species with any particular sign or symptoms of periapical periodontitis. So we could not relate a certain symptoms or sign to certain species of bacteria. We could not find this strong relationship. If we want to categorize the bacteria inside the necrotic pulp space, we have two patterns of bacteria distribution through the root canal system. We are dealing with first planktonic state, which are bacteria suspended in the fluid phase of the main canal or enmeshed in the necrotic tissue. So this type of bacteria may be easily accessed and eliminated by root canal preparation. So those types of bacteria which are not organized and they are not stick on the walls of the canals, it is easy to be eliminated by using files and proper irrigation. So it is easy to eliminate this. And this is not our main concern. Our main concern is with the second type, which we call it biofilm. The biofilm bacteria, they are bacteria which attach on the surface of the canal. They are enclosed in a self-produced extracellular polymeric matrix. And as you can see here, the blue color, this is for Rikuchi. He has a nice slide. This is a biofilm bacteria which are attached on the wall of the canal. The bacteria in the biofilms are often seen penetrating the subjacent dentinal tubules. So those bacteria, 70 to 80% of the teeth with periapical periodontitis, we see the microorganisms inside the dentinal tubules. And this invasion might be shallow or deep. A shallow penetration is more common, but bacterial cells can be observed reaching approximately 300 micrometers in certain teeth. So they are not shallow. They might go inside deeply, inside the dentinal tubules, and because of this, we might have persistent inflammation. Bacteria organized in biofilms are more difficult to reach, more difficult to eliminate, and may require special therapeutic strategies to be disrupted and eliminated. And if you want to know how much the severity of the biofilm, look at this article. They said microbes within the biofilm can be about 1,000-fold more resistant toward antimicrobial agent than their planktonic counterpart. So when I tell my students we have to spend more than 30 minutes in irrigation, now you can estimate why we need this, because the biofilms are so difficult to eliminate, and because of this we need a lot of time of irrigation to remove them. And this is our main problem nowadays, because we can make root canal preparation and shaping within a few minutes with the highest technology of endomotors and files. So the central incisor, it will take about 2 to 3 minutes to finish. The molar between 10 to 15 minutes to shape the canals. But does that mean our canals are clean? Absolutely no. And now you can understand why, because the biofilm is more resistant than the planktonic bacteria. Another important issue I want to elaborate. The number of microbial cells is well recognized as an important factor for microorganisms to cause disease. Sequeira made a new diagram showing us how the effect of the number of microorganisms. He said bacteria have to reach a quorum of cells sufficient to cause disease, and he named this with bacterial load, which means this is a number of microbial cells and we have a threshold. The microbes, before the microbes reach the threshold, we have no signs, no symptoms. When the number of and because of this, sometimes we see such a case here. There's no vitality test, and the patient has no signs, no symptoms, no periapical lesion. Why? Because the number of microorganisms now are not proper. So now we understand why those cases have no signs, no symptoms, because of the number of microbes. They did not reach the threshold. Look at this interesting case here. This patient has wires inside. The root canal was done long time ago, and he has no pain, no lesion at all. Why? Because now we understand we don't have a sufficient number of microbial cells to cause the response and the disease. Now, when the number of microbial cells exceed the threshold, what will happen? Periapical lesion will occur. Because of this, when the number increases due to more nutrition, different conditions of oxygen, those microbes will increase in number, and because of this, periapical lesion will appear. And we can see the patient, sometimes if it is in acute phase, he comes with severe pain or swelling or abscess, or sometimes in case of a chronic condition, we just see periapical lesion in the x-rays. And now we understand we have a number of microbes which cause this periapical lesion. So the successful treatment for periapical lesion, in the old days, we said we have to eliminate bacterial populations, and we have to get rid of those microbes from the root canal system. But we discovered all instrumentation technique, they will leave about 35% or more of the canal surface area unchanged. So elimination of microorganisms completely from the root canal system is impossible mission. Because of this, nowadays we are not talking about elimination of bacterial population. We are talking about reduce bacterial population to subcritical level that are compatible to healing. So we want to take those microorganisms to become below the threshold, so the lesion will disappear and healing process will occur. So the treatment for us is to reduce the number of microorganisms as much as we can by removing the maximum number of microbes from the root canal system. And of course, we do this by making proper cleaning, shaping, irrigation. We spend a good time with irrigation. We activate the irrigant with ultrasonic activator. Then when we fill the canal, we hope if remnants or a small amount of microorganisms stay inside, the body will deal with them, and after a while the healing process will occur, and this of course it will take time. So when we see this huge periapical lesion here, we understand we have a lot of microorganisms inside. So we will do our best by using proper files, proper motors, proper technique of irrigation, proper obturation ways, and then to seal the canal. And we hope the body will take care of remnants of microbes if they stay inside, and then after a while we will see this nice healing. Now let's go for the second question. Now we answered the first question, why they occur, and we knew the role of microorganisms. Now what is the periapical lesion? And is the periapical lesion a sac of microbes outside which needs surgical intervention? Let's take a look at the periapical lesion. And we have to know first, the periapical lesion, it represents resorption of bone. So when we see periapical lesion in the X-ray, CBCT or periapical X-ray, this black hole here, it represents the bone loss or resorption of bone. And this resorption of bone is due to direct tissue destruction, which is induced by bacteria and bacterial byproducts like enzymes, endotoxins, and from a immune reaction. So the resorption is due to the direct effect of bacteria or indirect effect of the immunity cells. Why this bone resorption occur? Because we need a space, and this space is created for the migration of the body's defensive elements to counteract the ongoing infection. So you can imagine here, this bone resorption, this tooth which is filled with microorganisms, caused bone resorption. And in this space, we have what? We have like a wall. And this wall is composed of granulomatous tissues, defense elements, polymorph neutrophils, antibodies, complement system, epithelial. This wall is filled by a body to stop the invasion of microorganisms to the rest of the body. So when I see periapical lesion, I know we have a fight, and this fight is between immunity cells and the microorganisms. My role as a dentist is not to eliminate the immunity cells by going into surgical intervention, but by helping the body to get rid of the microorganisms inside the root canal system. So when I get rid of those microbes by cleaning, shaving, obturation, those immunity cells will disappear gradually, and then this wall will stop. Now, bacteria might invade the periradicular tissue and have the potential to spread to other anatomical space of head and neck. So if this wall could not stop the bacteria and bacterial byproducts, the bacteria themselves, they will go outside the foramen, they will invade the body, and they will reach to the periapical area. And in this case, we will see what we call acute apical abscess. And if we do not intervene, sometimes this abscess might go into causing a facial space infection or septicemia, or in rare cases, death. Because of this, we should always focus on reducing the number of microorganisms from the root canal system. Now, let's have a look at the classification of endodontic periapical lesion. You can see, according to Nair, he said, the inflammatory periapical lesions are diagnosed into 3 categories. First, periapical granuloma. And this periapical granuloma, it's a chronic inflammation located at the apex of a non-vital tooth, and it contains diverse inflammatory cells like lymphocytes, plasma cells, macrophages, and mast cells. So the percentage of granuloma among those endodontic lesions is about 50%. So 50% of endodontic lesions are granuloma. The second type, it's periapical abscess, and it's acute or chronic inflammation of tissue surrounding the apical portion of a tooth. It consists of a collection of pus into a cavity formed by tissue liquefaction. And we can see the abscess and the swelling caused by this abscess. When the patient comes to our clinic, he has a swelling, and sometimes it is with severe pain. And we have to know the percentage of abscess among the endodontic lesion. It's about 35%. Now, the third type, it's called periapical cyst. And this is very confusing for several dentists. So let's take a look at the periapical cyst. Periapical cysts, they form about 15% of endodontic lesions. But we don't have one type of periapical cysts. We actually have 2 types. The first type, it's called a true cyst. And this true cyst is a distinct pathological cavity completely enclosed in epithelial lining. There is no communication to the root canal will exist. And this true cyst, it will form about 9% of endodontic periapical lesion. The second type of pocket of cysts is called false or pocket cyst. It's epithelium-lined cavity that are open to the root canals. They form about 6% of endodontic periapical lesion, and we can see it is connected to the root canal. Now, we have always 2 questions. First, can periapical lesion be diagnosed by X-ray or CBCT? Can we differentiate between those three types of lesions if we look at the X-ray, either periapical or the CBCT? The answer, it is no. It cannot be differentially diagnosed into cystic and non-cystic lesion based on radiographic alone. The second question, even though the lesion is big, round, with corticoid margins like this, can we say here this is a cyst because we have a large corticoid margins? The answer is no. The diagnosis of cyst as well as granuloma cannot be made radiographically. So, according to this, 91% of the lesions, which include granuloma, abscess, false cyst, all of them, they will heal after proper root canal treatment. And I mean by proper root canal treatment, proper access, proper root canal preparation, proper obturation, proper restoration, all of them, they will lead to healing. So, if the endodontic lesion is periapical granuloma, it will heal if we make proper root canal treatment, proper cleaning, proper shaping, proper obturation. I have no doubt this will heal after a while because it forms about 50% of the endodontic lesion, and just by making root canal treatment, it will heal. What about abscess? Here, periapical lesion, granuloma, if we make a treatment, it will heal. But what about periapical abscess? Even periapical abscess like this case, we have a huge abscess here with bad quality root canal treatment. If we make proper root canal treatment, and then if we can reach to a state where the canals become dry, I have no doubt this lesion will heal after a while. What about endoperial lesion? Endoperial lesion, if the cause is from the root canal, this periodontal lesion, it will heal after proper root canal treatment, as we can see here. And this is the X-ray after 13 years. So what about pocket cyst? A periapical pocket cyst may heal after conventional root canal therapy with just root canal treatment. So here I have a huge lesion. And frankly, I don't care if this is a cyst or not cyst. If I can clean and dry the canal, and I will place my obturation, I have a good chance to have a healing after a while. So let's see this case after about 13 years or 12 years. We have excellent healing here. Whereas an apical true cyst is less likely to be resolved without surgical intervention. And you can notice here the word less likely. They did not say never. I have 6 home messages before leaving. First, dear colleagues, please stop using the term cyst. We have to change it into periapical lesion because periapical lesion term is more suitable. So when we have a huge lesion here, we will say this is endodontic or this is periapical lesion. We will not call it cyst because the term cyst, it means we are justifying surgical intervention. We will call this periapical lesion. We will go for proper root canal treatment and healing will occur. My second message, periapical lesion need not to be medicated to disappear because our problem is not outside the canal. Our problem is inside the canal. So the role of dentist is to get rid of the microbes inside the canal and let the body handle what is outside the canal. Third message, dear colleague, be patient. healings needs time, because some colleagues, they are in hurry. They want to see healing quickly. Look at those two studies. Apical periodontitis lesion usually takes 6 months to 2 years to heal completely. So from 6 months to 2 years, when we have a lesion like this here, and we make a proper root canal treatment, I don't expect to have a healing after a few months. Sometimes it takes 1 year or 2 years. So here we spend 1 year to get this nice healing. But what about this case here? According to this gentleman, he said, it is almost a consensus that if an apical periodontitis lesion has not healed after 4 years, there is no reason to wait longer for revision of the root canal procedure. So here we are waiting 4 years. So now we have a frame time between 6 months to 4 years. So look at this case here. We have big lesion. And I spent 6 visits to enable me to place the final obturation. Now let's see the healing process. After 1 year and 3 months, the healing was starting, but we still have a lesion. Does that mean it failed? Absolutely no, because it needs time. Let's see the case after 4 years, we have complete healing. So give it the time. Another message. Another case here, you can see big periapical lesion, and this, my colleague here, he was planning to refer it for surgery. I told him, why not to give it a chance for treatment? So my message here, surgical elimination of periapical lesion is not required to achieve healing. So we will not think anymore with making a flap, inculate the lesion, because we have nothing here to remove. We only have immunity cells. What we are doing is just to harm the body. The body is sending you a message. Get rid of the microbes from the root canal system and the lesion will disappear. So surgical intervention is not required here. What we need here is just to make proper root canal treatment and waiting. And when we hear waiting, now all of us, we are waiting in our home for recovery. So just wait the tooth to recover. Another message. Periapic bacteria located inside the dentinal tubules are protected from systemic antibiotics. So please don't give antibiotic to cure periapical lesion. We could not eliminate the microbes inside the canals with antibiotics. We just need cleaning and shaping, and that's it. So, chemomechanical preparation of the infected root canal, followed by obturation and coronal restoration, all of them, they will provide successful treatment. And because of this, when we face a case like this with big periapical lesion, we will think with just one treatment, proper root canal treatment, proper obturation, and then we will have a healing. Whatever the size of the lesion like this here, huge lesion, whatever, I will make proper cleaning, proper shaping, proper obturation. We have also perforation here. We will close it and then we will wait healing. And I have no doubts of healing. Even this huge lesion here, I will make proper root canal treatment. If I can reach to a state where the canals are dry, I will make my operation and I will keep it under observation. Let's see this case after 6 months. It is my pleasure to share you with my final case, and it's very interesting, and I made this for this webinar. This lady, she visited me in 2005 with a huge swelling, and when I took X-ray, I can see here periapical lesion in the lower first molar. So all of us now, we know this is improper root canal treatment, and because of this, the number of microorganisms, they exceed the threshold and they cause this lesion. And it caused periapical lesion. All of us now know the treatment is as simple as possible. Means we have to make good root canal treatment, good obturation, good restoration, and that's it. And our main goal here is to reduce the number of microorganisms inside the root canal system. And then by doing this treatment, what will happen? We expect after a while healing process. So that was in January 2005. Let's see, in September 2005, we start healing process. As you can see, the size of lesion is decreasing. Let's see the case after 2 years. We have good healing. And 3 years, we reach to a healed condition. Everyone was happy. I was happy. The patient, she was happy. The signs and symptoms disappeared, and everything was great. But remember, if you look at the diagram of Sequeira, we can see this area here, which is not reached to the zero, which means we still have certain number of microorganisms inside the root canal system, but those microorganisms are inert, they are inactive, they will not cause any signs and symptoms. Bear this in mind, and let's continue the case. In 2011, this patient came to my clinic with a huge swelling at the same area. So now the swelling occurred there, and I hoped at that time it is not the same tooth. So I took an X-ray and I noticed it is the same tooth which we did 6 years ago, and with a lesion here. So what happened and why it occurred? So I have one explanation, which is we have microorganisms inside, those remnants of microorganisms inside the intestinal tubules, and those microorganisms, they stayed a long time and they decided to do honeymoon. They multiplied, and then periapical lesion occurred. This is the only explanation. So what to do now? What to do now? Let's inverse and let's start again with the process. So I will make retreatment for the root which we have lesion underneath, and I will make proper irrigation, proper obturation, and I hope to reduce the number of microorganisms to reach to a threshold and below the threshold. So I did this in October 2011. Now let's see the case and the progress of this case. So this is here after 1 year. Healing process started. Three years. Five years. And here we are again. After 8 years, we reached to a full healed process. I hope you enjoyed this webinar, and I am so happy to be with you here. I'm ready to receive your questions. Thank you so much, Ivy. Thank you, Eti, for this invitation, and stay safe. Thank you again.